Let's talk about what makes cystic fibrosis-related diabetes different from other types of diabetes and what you need to know to be prepared. Cystic fibrosis-related diabetes can be related to 3 different causes. The first is that people with cystic fibrosis often have insulin deficiency. This is likely due to scars in the pancreas that are caused by thickened mucus. This scarring will cause damage to the beta cells that make the insulin the body needs. The second is that people with cystic fibrosis can also be at risk for increased insulin resistance, similar to what is seen in type 2 diabetes. This just means that the body does not use the insulin the pancreas has already made well. Blood sugars then remain elevated, and the pancreas sees this as needing to make more insulin to keep the body's blood sugar normal. In cystic fibrosis, often underlying chronic infections can make insulin resistance more likely. The last contributing cause to CF-related diabetes is increased levels of cortisol, a steroid produced in the adrenal gland, an organ just above your kidney. Cortisol can be elevated for 2 reasons. 1, because of the chronic underlying infections associated with CF, and 2, the need for chronic steroid use to help maintain lung function. People with CF-related diabetes can fall into several different categories. 1, impaired glucose tolerance. 2, CF-related diabetes without fasting hyperglycemia. And 3, CF-related diabetes with fasting hyperglycemia. What should you be looking for? Some of the signs of CF-related diabetes include polyuria, which is increased urination, polydipsia, which is increased thirst. Other symptoms include blurry vision, drowsiness, losing weight, or being unable to gain weight. And finally, decreased lung function. Testing often includes an oral glucose tolerance test. Blood is drawn to measure a baseline or fasting blood glucose level. Patients will then drink a glucola. Blood work is then drawn 2 hours afterwards. If your child has a blood glucose greater than 200, they will be diagnosed with diabetes. If the baseline glucose is greater than 126, they have CF-related diabetes with fasting hyperglycemia. Complications of CFRD, if left untreated, include decreased lung function, kidney damage, weight loss, nerve damage that could lead to pain, recurrent infections, and eye damage leading to blindness. Treatment for CF-related diabetes will include insulin and nutrition. It is important to be aware how the nutrition is different for those with cystic fibrosis-related diabetes. Carbohydrates are turned into glucose by the body and will raise the blood sugar. Fat and protein are an important part of the diet needed to help maintain weight. They do not alter the blood sugar as quickly. The grams of carbohydrates, fats, and proteins per serving, and how big the serving is, are important to look at on a nutrition label. A nutritionist can help you formulate a plan specific to your child's needs. Common foods with carbohydrates include bread, crackers, beans, lima, kidney, and pinto, starchy vegetables, potatoes, corn, and peas, milk and yogurt, fruit, juices, and desserts. These foods should be taken into account when counting to see how much insulin your child needs with each meal. Protein will often help build muscle and can help add calories. Common foods with protein are fish, beef, beans, and chicken. These foods will not alter blood glucose that much, but will be important for weight gain. Fats also have very little alteration of blood glucose. Common foods with fat include oil, butter, and sweets. Unsaturated fats are healthier than saturated fats. Examples of foods with unsaturated fats include mayonnaise, margarine, nuts, and peanut butter. Foods with saturated fats include gravy, bacon, and sour cream. The second therapy needed for CF-related diabetes is insulin. Normally, insulin is required for the body to utilize the glucose taken in. Supplemental insulin is given by injection. Insulin injections are required for 3 reasons. Long-acting insulins will provide your child's body with a small amount of insulin continuously throughout the day. These insulins will often have no peak and last for 24 hours. Rapid-acting insulins will be used to cover carbohydrates eaten at meals. These insulins will usually start working in 15 minutes, peak at 1 to 2 hours, and last 4 hours. Rapid-acting insulins will also be used to give correction for high blood sugars and bring them back into a normal range. Blood sugar readings are recommended before meals, 2 hours after each meal, at bedtime, and at 2 a.m. After your child has been on the same doses of insulin for a long period of time, blood sugar checks can be decreased. Logbooks are great for keeping a log of your child's blood sugars so that your doctor can look at patterns and make the needed adjustments to your child's insulin regimen.